Do you know your real risk of heart attack? Stay tuned, you may well be surprised. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Welcome back to the Healthy Heart Network. I'm Dr. Warrick Bishop, and in today's episode, I'd like to cover a couple of things. First of all, I'd like to talk about our current approach to stopping heart attacks. I'd like to define the difference between primary and secondary prevention. What is population versus individual-based risk and what that can mean for you? I'd like to talk about association and causation, and I'd also like to touch on screening. So first of all, let's start with secondary prevention, because there's really very little controversy here in the literature. Well, what is secondary prevention? Secondary prevention, in our language, in doctor language, means we want to stop a second event. So we're talking about people who've already had an episode, maybe a heart attack, maybe chest pain or angina, proven to be their heart, shortness of breath from heart-related problems, perhaps someone who's had a stent or even a bypass. When it comes to secondary prevention, what we're looking to do is to keep people as well as possible for as long as possible. That means we want to deal with their symptoms, keeping them as well as possible, and we want them to live as long as possible. We want to maximise their prognosis. We put in place lifestyle intervention, which includes perhaps diet, exercise, weight loss, cessation of smoking, management of diabetes. We use medications, tablets to keep the blood thin, things like aspirin. We manage blood pressure. Sometimes we even use medications to reduce chest pain. Sometimes we also put in place strategies to improve blood flow to the heart. And that's using stents to open up arteries or even grafting to bypass problems. I'm going to cover more of that in subsequent episodes. But what I really want to focus on today is primary prevention. This is stopping or preventing someone having the first event, which to me really makes the most sense. I also want to touch on this because in the literature, there is a little bit of leeway in terms of how we can approach this, and that's really what I would like to touch on. Well, what do we currently do to try and reduce that first event rate? How do we reduce or predict someone's risk? We start off by trying to evaluate someone's risk, and to do this we use risk calculators. Risk calculators are based on population assessments, where thousands of people have been observed, where the people who have had an event, a heart attack, their characteristics are assessed, and the rates of those characteristics occurring predict the rates of someone with those characteristics potentially having those events in the future. We call those traditional risks, and the most famous traditional risk calculator is the Framingham risk calculator, which was established back in the 1950s. Those risk calculators allow us to characterise or categorise patients into low, intermediate or high risk. Now, what does that mean? Well, in medical talk, we talk about low risk being less than 10% risk of a heart attack in 10 years. We talk about high risk being over 20% risk in 10 years. Let me give you an example to try and make that a bit clearer. Imagine you are a 50-year-old male. You've got average blood pressure and cholesterol, you're a non-smoker, you don't have diabetes, you do a little bit of exercise, but never enough, because who does? Your weight's just a little more than you wish it were. You don't have a family history of heart disease. Most risk calculators would put a man like that in the intermediate risk category, approximately a 10% risk in 10 years. In my own practice, and in practices right around the world, patients would go and see their doctor for that risk assessment and be told your risk is 10% in 10 years, and most guidelines don't recommend treatment at that level because it's considered a fairly low or intermediate risk of event. As the patient, you do a quick calculation in your head and think 10% risk in 10 years, that's only a 1% risk per annum, and that doesn't sound so bad. The doctor feels pretty good because the guidelines don't necessarily recommend treatment. But what if we were to reframe the way we present that information? What if you were that 50-year-old man and I turned around and said to you, based on the characteristics you've just shared with me, What I can tell you is that if we take 100 men with exactly the same characteristics and follow those 100 men for 10 years, 10 of them will have a heart attack. And in all honesty, I don't know if you're one of the 10 or one of the 90. It's exactly the same statistic, but when you frame it that way, it's slightly more confronting. And you suddenly realise that risk represents what can occur in the population, but actuality is what happens to you. Because your actuality will either be a 0% event rate over 10 years or a 100% event rate over 10 years. You're the one of the 10 who has the event. This is a really nice way to consider it, actually, and if you were part of this choir, you would be hoping you weren't one of the tenors. So he's saying, okay guys, I've spoken to the doctor. He says 10 to 15 of you will have a heart attack in the next 10 years. Could I just ask that it's not all the tenors? So this really raises the possibility, what if we could actually take those 100 men? What if we could take this 100-man choir and put them through some sort of process? What if we could scan their hearts and actually get a better idea of the health of their arteries and break those people down into good, bad, and somewhere in between? Well, do you think that could be helpful? You bet. Many people misunderstand these fundamental concepts, the difference between risk and actuality, and the difference between association and causation. Well, my experience is that plenty of patients may not be interested in scanning their hearts and will say things like, oh, well, I'm okay, doc, I eat well, I exercise regularly, there's no bad hearts in my family. Well, these are just associations to heart attack. Let's talk more about association and causation so that you understand it. And a really easy example is if we think of speeding and alcohol in the setting of car accidents. Everyone would agree that if you speed and if you drink alcohol, you're at higher risk of a car accident. There is no question about that. But we do know that people speed or people consume alcohol and they don't necessarily have a car accident. We also know that there are people who neither speed or neither take alcohol and do have a crash. Speeding and alcohol are associations to a vehicle accident. They are not the causation. And it's important you understand that the traditional risk factors that we talk about in health are exactly the same. So if you think your blood pressure is okay, that you eat okay, that your family history is fine, that your cholesterol is okay, that you exercise, any number of associations you like, and you think you might be okay, then you might be right. But you may also be kidding yourself. In all honesty, do you decide not to take your car for a regular service because it happens to be running well? Let me give you an example. This is a I'm pretty fit doc. So I'll tell you a story about a 61-year-old fireman who was on a bit of treatment for blood pressure, a little bit of a family history of coronary disease. He didn't smoke, his cholesterol was pretty average. He'd gone through a treadmill test and done 12 minutes, which is a really good exercise level. I suggested to him though, we might just want to be a bit clearer about what's going on with the health of his arteries. And so we scanned his heart, and this is what we saw. You can see without question that there's build-up of abnormality. This is normal, healthy-looking artery, here and here, and you can see these dark and white spots that clearly represent rust in his pipes, way beyond what we would have imagined by looking at him. This just shows you that we don't know what's going on until we have a look. It also tells us and reminds us of one of the problems of treadmill testing for primary prevention. Remember the story of the fun runner in the first episode. Stress testing will only tell us if there's blockages, not tell us the health of the arteries before a blockage occurs. So this fireman's arteries were not as healthy as he looked on the outside. So in summary, there are several points I'd like you to take away. First of all, the difference between primary and secondary prevention. Secondary prevention is potentially too late. Primary prevention, I think, is where we really need to focus. Number 2, I want you to understand the difference between association and causation, and don't kid yourself. 3, I want you to understand how we go from a 10% population risk to start to moving toward an individualised risk, finding the people in the crowd who could be at greater risk of having an event. And 4, I want you to define and think about your real risk of heart attack. Please stay tuned for our case study, Mark, a 55-year-old endurance athlete. Hi, you'll now be well informed about risk calculation, and now I'd like to share with you the case of Mark, a 55-year-old male professional who is married with 3 kids. He enjoyed exercise and he had done for years. He was fit and well. In fact, he was putting in 6 to 10 sessions per week of exercise at a high intensity. This was a man who was an endurance athlete. He had undertaken a Hawaiian Ironman. He'd done a Coolangatta Gold, which again was an endurance distance event. And he'd literally come to ask about whether CT imaging might be appropriate for him because he'd heard about it. There was a little bit of a family history of coronary disease, but certainly nothing compelling. His lipid profile, his blood cholesterols and labs were all fairly unremarkable, though he did have a lowish good cholesterol, the cholesterol we call HDL. He had absolutely no symptoms. He was as fit as anyone you could imagine. He had no other risks and he was on no other medication. We did speak about the role of imaging to try and be more precise about his particular risk. And if you remember the fun runner, it is quite possible to look fit and well and trained on the outside and yet have arteries that aren't necessarily in as good a shape. So we did elect to get his heart scanned, and this is what we saw. You can see very clearly white spots here which are calcification. He had significant build-up of plaque in his arteries or rust in his pipes. So significant that if we'd left him without treatment or without therapy, his risk would be unacceptably high into the future. So this information gave us the opportunity to put in place strategies to mitigate or reduce that risk as much as possible. Mark is now on all the medication that you would want to put someone on if you were trying to stop a problem with coronary artery disease. He's on aspirin, he's on a cholesterol lowering tablet, he's on a blood pressure tablet to make sure we always keep his blood pressure down. He's on a supplement called nicotinic acid. He takes some fish oil to keep his triglycerides down. He's on coenzyme Q10. We've also put him through a stress test so we could be objective about whether there is any impact of this build-up within his coronary arteries. His stress test showed no problem at all, and we're completely satisfied that although there's plenty of rust in the pipes, it's not causing any narrowings. I'm pleased to say he has continued with his sporting interests. He regularly is involved in competitive paddling, cycling, running and swimming. He's not required any further investigation. He's not had an invasive coronary angiogram. He is now educated and aware, so he now knows what's going on in his arteries. So should there ever be a change in his exercise capacity or symptoms, he knows to take that seriously. We also have put in place a surveillance program, so I follow up with him on a regular basis just to make sure things are running smoothly. All this information also allowed us to engage Mark in a conversation about screening his family, which we've duly done, and we've put in place appropriate medical strategies for them as well. Overall, a great outcome for everyone. Stay tuned for the patient question session. Welcome back to the part of the show where I answer patient questions. Today's question is, what is the controversy with statins? This is an area that I think is a little bit confused, so let me try to simplify it. There are two main issues that we need to sort out. Some people say that statins are not for everyone, that there are people who have high cholesterol who may never have a heart attack. Well, that's true. The second issue is related to statin side effects. Well, that's true also. There isn't a medication available that's free of side effects. But let's deal with those 2 points in more detail. If we suggest treatment to prevent an event or after an event, then we're considering primary or secondary prevention. If it is after an event, then it is clear-cut. There's no debate. The data in the science and the literature is very clear. High-risk individuals who have had an event have been shown in trial after trial to benefit from lowering cholesterol, and that's using any form of cholesterol lowering in actual fact. The most recent trials using agents to lower cholesterol have lowered cholesterol levels to very low levels, and these have even shown a benefit without any negative marker, without a flag suggesting that you can go too low. This data, in fact, supports the concept of an LDL hypothesis or a cholesterol hypothesis, which is if you're at high risk, the lower you can get your cholesterol, the lower your risk of an event. For an individual before they've had an event, it's a different story. We're talking about using population-based probability to estimate the benefit. If we say that an individual is at 10% risk of an event in 10 years, or that they are at 90% risk of being okay, the issue is not the statin, the issue is finding who will benefit most from taking the medication, by finding the people who will actually be at high risk, not at low risk, in that group of people. And this then has to be considered in the context of risk and benefit for the individual. In my own experience, I tend to take intermediate risk patients and look to scan their hearts. This gives me some insight. If there's nothing going on in their heart, no plaque, no evidence of build-up of cholesterol, or calcium for that matter, then the case for treatment is not particularly strong. And the discussion with the patient can be about modifying risks and not necessarily needing a cholesterol-lowering agent at that time. The reverse, of course, is true. So the second issue with statins is that of side effects. Well, they are almost certainly one of the most prescribed drugs in human history. What do you expect? The most concerning side effect is one that is completely unpredictable. The word we use for that is idiosyncratic, and that side effect is muscle meltdown. The other word we use to describe that is myositis or myopathy. There's no question this is a concerning side effect and one that we're aware of. It occurs in about 1 in 70,000 people. It is severe and it is life-threatening. Prescribing statins make the most sense if you're sure the person will benefit from it. That's partly why I scan, to be clear exactly what I'm dealing with. Other risks associated with statins include an increased likelihood of demonstrating some diabetes. Some patients demonstrate some liver function abnormality. Problems with the nerves has been reported. Some people report that memory becomes affected by taking cholesterol tablets, but there is no trial data to support that, and it has been closely looked at. In that situation, you have to go on a patient's personal experience, not what's available in the literature. The most common side effect, though, is muscle aches and pains. We describe that with the word myalgia. This is a really interesting space, and it's hard to pin down, but I'll tell you about 2 recent studies using tablets or medications to lower cholesterol significantly and look at side effects. These 2 trials took patients who indicated they were statin intolerant, unable to take statin medications because of side effects. These patients were then given a placebo or a statin as a run-in before trying one of these newer agents. It turns out that after evaluating these patients who were given a cholesterol-lowering tablet or a sugar pill, that after 2 to 3 months, 70% of patients who were adamant they were unable to take statins were able to take statins at the same rate of complication as placebo by the end of that study time. Well, what does this tell us? It tells us that there's a good number of people who get aches and pains and blame statins, possibly inappropriately. It also tells us from those studies that probably 20 or 30% of people really do have symptoms, and we need to be aware of that. So statins, are they friend or are they foe? Well, they're certainly a friend if you need them, and they're probably a foe if you don't. It's that simple. Well, that concludes this episode. Thank you for joining me. I hope you feel educated and informed, and you're looking forward to the next life or death episode. Until next time, please don't have a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover, a paperback, and an audio from Amazon, or wherever good books are sold.